Hi there, this is Sarah Van Valkenburg presenting on Segal's Chapter 5, A Rhetoric of Death and Dying. I couldn't get my face to show on the screen while I was presenting my slides, so I'm just going to talk over these slides as I narrate them for you. In Chapter 5, Segal starts by presenting Perelman's and Ulbricht Titeka's conditions for rhetoric, which include three main conditions: a contact of minds, a common language, and a mutual respect, so that when a conversation is actually happening or when true rhetoric is happening, those three things are present. Um, and then she goes on to say that the problem that her chapter is going to address and that the studies in this chapter address is that the end of life decision making frequently takes place in conversations between people who are medical experts and people who are not, which results in these assertions she's going to make that results in a problematic nature of end of life discussions between medical professionals and the patients or their family members, along with the fact that there are then competing discourses of death and dying, and some means of traveling between these discourses is necessary in order for the most productive rhetorical process to take place. She also is going to pose a question in this chapter, that is the medical expertise at the front and center of end-of-life conversations the most important expertise to have in matters of life and death? Voices and language of the clinicians and physicians present are prioritized, and she's going to question that in a few different ways through the chapter. According to biomedicine, these are the two competing rhetorics that we have here. According to biomedicine, the body's defenses fight invading disease, and medications are the magic bullets that target the enemy. Physicians are the warriors meant to defeat death and save us, and rhetoric portrays death then as a medical failure if those things can't take place. But in public discourse, death has become a much more discussed situation in the past several years. It is now considered a matter of reluctant inevitability. It's a part of life. It's discussed in a much more now inevitable way than what biomedicine is willing to portray it as. So Segal first goes into then the single case study, which covers her experience in the months leading up to her mother's death. This is when her mother had been weakened and left with lessened physical ability from a previous stroke and a case of pneumonia. And so she then engages in suffering in the months leading up to her death, and this was Segal's memories of her and her sisters dealing with physicians during that time. The data is conversations between the family members and physicians as written and remembered by her, and recorded facts about the events that took place during these months. These conversations, as she records them in the chapter, they take place primarily with the doctor as the authority figure, not always answering questions the family members were asking. At one point, when one of the daughters asks if they've done other tests to rule out something specific, the physician just flat out answers no, and I don't think tests are warranted at that time. Later on, discussing something else, no, that's not an option. And then at one point when the daughter asks a specific question, how do you know something? The doctor deflects by positing a different comparison and not actually answering the question that was being asked. Along with this, the subject of death was taboo, Segal says, so that when she and her sister wanted to discuss their mother's eventual death, not as a right to die kind of event, but just it's going to happen at some point. Can we start discussing what that's going to look like? The doctors, for months, weeks, and into months, would only allow discussion of continued interventions and treatments that would prolong their mother's life. And she says it was the opportunity to consider on its own terms this death, our mother's death that we missed. And so there in the way that she talks about this. Takeaways from this single case study of her mother's death is that a large disconnect exists between the biomedical rhetoric on the one hand and a public, more human one on the other. It refers to what I said at the beginning. She says on page 101, increasing communication of the existing sort is a less promising idea for end-of-life care than changing the very terms and structure of communication, changing, that is, the usual discourse of the hospital. Here she's referencing the support study that was presented in Journal of the American Medical Association. In this study, the researchers were hypothesizing that increased communication between patients and families and medical professionals would improve the end-of-life experience. But when they tried to engage in that increased intervention to produce increased communication, they found it produced no significant improvements in measurable patient outcomes because, as Segal is alluding to here, if it's the same type of communication where there are two different languages basically in existence, and are talking past each other, increasing more of the same isn't going to help. Something has to be changed. The discourse has to change. And then Segal said over on page 101 that based on, again, referring to Perlman and Ulbricht-Titeka's criteria for a real rhetorical situation, in the months before her mother's death, she was engaged in a false rhetorical situation and it left her powerless except when she stepped outside it or flouted it. Because remember, she says, according to these two theoreticians, that a real rhetorical situation is one in which interlocutors speaking the same language use persuasive strategies to arrive at the best course of action. And so, based on that, she doesn't think she was actually in a real rhetorical situation there. The Riverview Project, the second study she discusses, had a goal of establishing protocol for communicating between health professionals and family members, aiming towards shared decision making for seriously ill or cognitively impaired patients. And so this was this is different from the previous case study, and that this team at this hospital, this was a hospital in British Columbia, Canada, this team is intent on having shared responsibility and shared decision making in place, and they believed that doing that would result in better decisions for levels of care and for advanced directives for these patients. So Segal here observes it, or functions in the role of an observer and helps to facilitate communication in these meetings. She finds that there are certain procedures or behaviors that exert rhetorical force or power on the part of the clinicians. For instance, the doctors always went first in the meeting in their describing of the treatment of the patient or the status of the patient. Their narrative was prioritized in the meeting, and that sometimes options were not really offered as options. They were described as unfavorable or not a good idea. And then she also saw that family members often take certain steps to try to participate more legitimately or authoritatively in the rhetorical situation. And this could be by adopting some of the medical language that they hear in the room around them, or trying to assert their own presence or what they believe the wishes of the patient to be. But they are trying to find their place and find a little bit of power in the situation. And so, takeaways here. She saw that morally shared decision making does not require that everyone knows the same things, but it does require recognition of a pluralism of expertise, that not all expertise looks the same, so that there is a proper rhetorical exchange among parties sharing respect and an agreed upon language for decision making. Structural changes can be made to conversations such that they will be more properly rhetorical, better designed to lead to the best course of action. Here she was referring to the idea that maybe it should be the patient's family members who talk first, because they might have a better, more clear idea of what a day in the life of their family member actually looks like, and that can kind of realign the power or readjust the power dynamic in that situation. But similar to the first study, again, this project makes clear the terms of a predominantly biomedical rhetoric of death and dying are not sufficient to provide a framework in which human beings can engage satisfactorily in a conversation about the end of life. And so it comes back to that common theme. So a final assertion from this chapter is that she came back to that rhetorical principle. Two people are not fully engaged in a rhetorical process if only one of them really knows what they are talking about. And she felt like that encapsulated the essence of this topic of end-of-life decision making. The two other articles that I got into this week, the first one was by Karen Koppelson over medical doctors' epideictic rhetoric of how to die. In this article, Koppelson analyzes rhetoric from 5 different books written by doctor authors who are writing about death and dying. Some of them are writing about their own experience of being diagnosed with a terminal illness and going through that dying process in the months leading up to what they know is a coming death, or discussing the deaths and dying processes of patients they have treated. In this context, Koppelson identifies this rhetoric as functioning as epideictic because the authors are generally giving us instruction about how to die well or virtuously and how to avoid dying badly. She sees these authors referring to the Greek and classical virtues of having the courage to accept death and stand and submit to it. But in doing this, they're also writing against the ethos and the standard mindset of the biomedical world, which emphasizes using technological interventions to prolong life. And so there's actually some tension there in what they're doing. Connections to Segal from this article. Segal, this is a little bit of a different look at it, but Segal in chapter two, I think it was last week, pointed out that the illness narrative genre may impose restrictions or mindsets that limit all voices from being heard equally or usefully. And Coppelson looks at this epideictic rhetoric a little critically and says, well, if you want to talk about dying well or give people instructions on how to die well, that's really only useful for those who are privileged enough to have the time and space to consider and prepare for their deaths. And not everyone is living the kind of life where they can thoughtfully think into the future and think about how they'll approach death or how they'll face it down. Um, then another connection is that the doctors that Segal encountered in her mother's case study could not address death as anything other than an enemy to be defeated and put off. In these doctors who are writing about death, Coppelson recognizes in them a concession to the reality and inevitability of death, but they want to claim a sense of victory somehow, and so they turn to preparing well and facing death courageously and on one's own terms in order to find that sense of victory. My second article was Imaginaries of Dying, covering the visual rhetoric of stock images tagged with palliative care. These authors look at stock images from online databases like Getty Images and Shutterstock and a couple of others that are tagged with the term palliative care. And the rhetoric they see, the visual rhetoric, they see it focusing on portraying a good death as one with entirely positive connotations, facing death with courage and contentedness, and excluding negative components like grief or despair. To do this, the authors use the ideas of visual grounded theory, where they use recurring image motifs to gain information about cultural constructions, to gain a conception of the Western understanding of what a good death is. And so they're kind of making their assumptions, or they're gathering their final understandings from what they see as the similarities across these photos. They saw the images that they pulled, emphasizing connectedness, light and beauty, healthiness, peace and lack of pain, a sense of the transcendent or divine, completely leaving out elements that would portray death as harsh or painful. So throughout all of those images, what we see here are a couple of possible connections to Segal's chapter. Segal found the doctors in her mother's case to be unwilling to discuss the possible nearness or the handling of her mother's death, and the rhetoric of these images seems to insist on portraying a good death to be one that lacks any sense of grief, isolation, or pain. That again connects to the Coppelson article, focusing on dying well, dying at peace and in control, and that's what these images seem to emphasize, was that sense of contentedness with the way that you die. And so these authors found that to be present. And then again, a disconnect between two different discourses. The authors, near the end of this article, the authors asserted that conversations with palliative care nurses reveal a preference for more realistic and versatile representations of death and dying, rather than just the rose-colored, very peaceful connotations that this genre of photos seems to create. And so there is a tension there, two different ways of talking about death or viewing death, one that seems intent on totally ignoring some aspects of death or of the process, and one that wants to approach it more realistically. We see there. As a final assessment, I think that what's pretty clear is that the topic of death and dying is a key area within the rhetoric of health and medicine, where differing narratives and languages keep effective communication and rhetorical relationship from occurring. Sometimes that's patients and family members who can't bridge the gap between public discourse on death and their doctor's faithfulness to the biomedical rhetoric and stance on death. Or it might be visual rhetoric that portrays dying as this pleasant experience in a beautiful nature atmosphere, and enticing families and patients to believe in the kind of death that kind of death that they might experience for themselves, and used in advertising to create that image of death or that hope of that kind of death. So Segal's assessment is that there is more work to be done in order to have more effective, helpful conversations about this topic. I think that's a valid one. But I think that's true about her, like the theme she seems to be developing throughout these chapters is that in most of these health related topics, there is a power imbalance of some kind. There is definitely someone in more power to control the situation, to control the rhetoric. And I think we see here that probably by virtue of the authority they hold in the field, the clinicians and the doctors seem to be able to control the rhetoric to fit their purposes more than patients and family members who walk into these situations are able to do. And so I think that's a common theme we're seeing throughout the book that definitely played into this chapter. That's about it. Thank you.